Okay, so we've got a patient here who's got pain underneath the second metatarsal here. So I'm going to go through all the different reasons why you can get pain here. If you're a patient or if you're a podiatrist, you might find this useful. So, second metatarsal head, proximal phalanx. It's good enough drawing. The different reasons why you can get pain here. First of all, you can get synovitis. Now, you can get inflammation of the synovium. This can happen in patients with rheumatoid arthritis. This can happen in other inflammatory conditions. The second thing that can happen is capsulitis, which is what this patient has. So it's pain in the capsule that surrounds the metatarsal head. It can happen, especially if you've got a bunion. Now this is a whopping bunion, huge bunion. This can occur in males and females. This is a semi-professional footballer who plays football professionally, and I see a lot of footballers that have feet that are mashed up like this, so really bad bunions, claw toes. If you looked at both feet, let me show you the other foot, that's also got a bad bunion. So that is one of the reasons why you can get capsulitis. Other reasons include wearing high heels. Now I don't think he wears high heels, maybe he does on the weekends, but you never know. But in females, wearing high heels can also lead to capsulitis. Now you can get a plantar plate tear. A plantar plate it's a structure, a fibrous structure that connects the metatarsal to the proximal phalanx. And the way you test it is you do a digital Lachman's test. And I've done it on both sides and I can't feel any laxity. There's no pain on that, and the toe is not deviating. But it can be that, and we're going to do an ultrasound scan to go through that. Other reasons, you can get an intermetatarsal bursa. So a bursa that is in between the metatarsal, but it pushes on the second metatarsal. Really common, you need to rule that out. Finally, actually a couple more things. Second to last, you can get an adventitious bursa. So usually adventitious bursas occur under the first or the fifth metatarsal or the heel. But if you've got a bunion, you're putting more weight underneath the second metatarsal, so you're more prone to get an adventitious bursa here. Finally, and lastly, you can get a stress fracture. Now we've ruled a stress fracture out. So what have we done for this patient? We've done a lot of conservative treatment. We've done shockwave, laser, insoles, special taping using the breast cancer sign taping, really great, offloading pads, rest from football, everything that we could do to help with the conservative management, including acupuncture and stretching, rehab, all of that. We've covered it all. Eventually, this chap here is going to need surgery on his bunion because I think this is going to happen again, even if we get it better. So we're going to do an injection today. Now, there's two options. We can do a steroid injection, or I'm going to do a Traumeel injection, which is a herbal injection. The reason why I'm doing a Traumeel injection and not Kenalog or Dipamedrone or anything else is I know of a couple of cases now where colleagues of mine have given a steroid injection for capsulitis, but the steroid obviously doesn't just stay there, it's going to spread, and it's caused or it's led to a rupture of the plantar plate. If the plantar plate ruptures, this toe is going to go like that or like that, and then it needs surgery. So rather than take the risk, we're going to do a Traumeel injection, and that should be a lot safer. A ultrasound of the second metatarsal. That's if I just do that, that's the toe moving. That's the second toe moving, which is over there. It's the flexor tendon, and if I just tilt that like that, you can see the plantar plate, which is intact. So we're about to do the injection now. I've marked out the extensor digitorum longus tendon, which you can see very clearly, especially because these toes are retracted a little bit. So you can get the extensor tendon. You want to miss, obviously, don't bloody inject the Don't inject the tendon. That wouldn't go well. Then you got the proximal phalanx and the head of the metatarsal. Now, normally I would do this ultrasound guided if I had somebody else helping me to pull this down to distract the toe. But I know I want to do this with a distraction and I only have 2 hands. Hence, we are going to have to do it without ultrasound guidance, but anatomically marked. Let's get some of this chloroprep. What we do is we're just going to give it a bit of a clean. Okay? Get some sterile gauze and we're going to just dry it out. Now, you have 2 options. You can either go in medially or laterally because you need to distract the toe while you're doing it. So what I'm going to do is I'm going to do it medially. Now, my patient here is incredibly brave because he's actually going to film. He's filming the procedure itself. So if his hand wobbles, you know why. I'm going to use a bit of cold spray. Now, I'm a fan of this because it takes the sting away from the needle. I know some podiatrists are not, but I am. So we just do a bit of that, and it freezes the skin. It's called cryogenic. That's very cold. So we're going to distract the toe, come in medially, 1, 2, there you go. And that is straight into the joint. Now what you do is, as long as you've distracted the toe, and you've got that needle at 45 degrees, I can feel that I'm in the joint. And this chap here hasn't even flinched. So either he's been having a lot of injections over the years, or he just can't feel pain. Ah, there you go. Well done. Well done.